Good afternoon, everyone. It's my pleasure to welcome you to the Human Nutrition Research Center on Aging Monday seminar series. I'm Dr. Roger Fielding, the Associate Center Director. It gives me great pleasure to introduce Dr. Denise Houston from Wake Forest School of Medicine. Dr. Houston has appointments as a professor in the Department of Gerontology and Geriatric Medicine, as well as Epidemiology and Prevention. She's located at the STICT Center for Healthy Aging and Alzheimer's Prevention, which again is part of Wake Forest School of Medicine. Dr. Houston's talk today will be dietary protein, optimal intake for maintaining function in older adults. So welcome, Dr. Houston. We're looking forward to your seminar.
Thank you. Can everyone see the slides? Yes, okay, great.
You want to put it in presentation mode, please?
Okay, so you're seeing the wrong screen. And we thought we had this all taken care of. How's that? Great. So the topic of my talk today is going to be on dietary protein and the optimal intake for maintaining function in older adults. As we all know, older adults lose muscle mass and strength with increasing age, and peak muscle mass and strength are typically attained in someone's 30s to 40s, and then begin to decline after that, with strength declining faster than mass. And what happens in older age is you see a range of loss in both muscle mass and strength. And that loss of muscle mass and strength could potentially put an individual below the disability threshold so that their function is impaired and they may lose their independence. Although there are many different underlying mechanisms for the loss of muscle mass and function, low protein intake has been hypothesized to potentially accelerate this loss. Our current dietary protein recommendations are based predominantly on short-term nitrogen balance studies in younger adults. And some studies suggest that the current recommended dietary allowance for protein of 0.8 grams per kilogram of body weight per day may not be optimal for maintaining muscle mass and function in older adults. So this is some recent data from N. Haynes showing the percentage of adult population below both the EAR and RDA for protein by age and sex. And although the average protein intake based on grams per kilogram of body weight per day is about 1.1 in older men and women, you can still see that there's a quite large proportion of women in particular, but also men who are consuming less than the RDA, with almost 20% of women consuming less than the RDA, and about 13% of men consuming less than the RDA. So there are a number of factors that lead to low protein intakes in older adults. The first being reduced energy needs. And while energy needs decline with age, typically the proportion of calories from protein stay the same, resulting in lower protein intakes. There's also changes in food preferences with age, such that older adults tend to prefer foods that are higher in fat and carbohydrates over protein. A number of medical conditions can increase the needs for protein intake, and often you see anorexia, issues with dentition, issues with taste and smell that can affect protein intake. With physical dependence, there are older adults who may not be able to access food or prepare their own food. And there are also a number of older adults who are food insecure and may not have the resources to purchase high quality protein foods. There's also a number of factors that could lead to higher protein needs in older adults. One of these being anabolic resistance, as well as decreased muscle perfusion of protein. The immobility in older adults, whether it's bed rest or just decreased physical activity, can increase the loss of muscle mass, resulting in higher protein needs for turnover, and then also insulin resistance. And then finally, disease-related protein breakdown occurs quite frequently in older adults, and this can also be the result of inflammatory processes. So while there are a number of cross-sectional studies that have shown that lower protein intake is associated with poor physical function, the longitudinal studies examining protein intake and physical function have been quite inconsistent. Both the ProTage study group and the ESPEN expert group recommend protein intakes of 1 to 1.2 grams per kilogram of body weight to maintain muscle mass and function in older adults. So about a 40 to 50% higher intake than our current RDA. So for the next piece of my talk, I'm going to be focusing on some data that we have looked at in the Health, Aging, and Body Composition, or Health ABC cohort. The Health ABC cohort is a cohort of older adults where the primary outcome was to look at body composition and fat on function over time, and was followed for about 18 years of follow-up. So the Health ABC cohort includes a little over 3,000 well-functioning at baseline, community-dwelling, Black and white men and women who were aged 70 to 79 years, and they were recruited from 2 sites, one in Memphis, Tennessee, and the other in Pittsburgh, Pennsylvania. The cohort was specifically recruited to be about equal male-female and about 40% African-American. Diet was collected at the first year follow-up visit in a little over 2,700 individuals, and was collected using a 108-item interviewer-administered semi-quantitative food frequency questionnaire. This food frequency questionnaire had its food list derived from a representative sample of U.S. adults aged 65 years and older who resided in the Northeast and Southern United States. And then the nutrient analysis was done by block dietary data systems. In Health ABC, because the focus was on body composition was measured by DEXA annually to begin with, and then a little less frequently in the later years. And for the analysis that I'm going to show here today that focus on lean mass, the bone mineral content was subtracted from total lean mass to determine total non-bone lean mass. We also looked at appendicular lean mass, which was calculated as the sum of the non-bone lean mass in the arms and the legs. As far as physical function measures in Health ABC, because the primary outcome is primarily physical function, both self-report and measured. These are the ones that I'm going to focus on today. There are others that were collected, but the first one is the Short Physical Performance Battery, or SPPB. This includes a standing balance task of side-by-side, semi-tandem, tandem stands for 10 seconds, a time short walk over 6 meters, and then repeated chair stands as quickly as the participant could do. There was also an extension of the Short Physical Performance Battery called the Health ABC Expanded Physical Performance Battery that increased the hold time of the balance stands to 30 seconds and included a narrow walk where the participant had to walk between 2 pieces of tape that were 20 centimeters apart. Both 6-meter walk pace from the SPPB and 400-meter walk pace were measured. The 6-meter walk pace is done at usual pace, whereas the 400-meter walk pace is done at fast pace, with the participant doing 10 laps of a 20-meter course. We also measured isokinetic knee strength as well as grip strength. And then our self-reported mobility limitation, which is the primary outcome for Health ABC, was assessed every 6 months, where participants were asked if they had any difficulty walking a quarter mile or climbing 10 steps. And the participant had to report difficulty on 2 consecutive time points for them to be considered mobility limited. So this figure here shows the distribution of protein intake in the Health ABC cohort. And what you can see is about a third of participants consumed at least 1 gram of protein per kilogram of body weight per day. However, about over 40% consumed less than the RDA. However, I'll note here that this is from a food frequency questionnaire, which doesn't capture total intake. So this may be, the number consuming less than the RDA may be inflated. Just some characteristics by their protein intake. As you can see here, the mean age was 75 and about 50% were female. We found that older Blacks were less likely to consume higher intakes of protein, as were non-drinkers and those who were sedentary. Current smokers, however, were more likely to consume more protein, and those who had a higher BMI were less likely to consume more protein. And this is likely driven by the fact that we are looking at protein per kilogram of body weight. Just looking at the dietary intake by protein intake, as expected, the people with higher protein intake had higher total energy intake, higher fat intake, lower carbohydrate intake. The percent of energy from protein was pretty consistent across the 3 groups, close to 15%, which is typically seen in most studies and across the world. And you can see that the amount of protein in grams per day increases with higher protein intake. For this cohort, we do see an increase with HEI score being higher in those with higher protein intake, but it's still in the range for needing improvement. So I'm going to start off by work we undertook about, I guess, 12, 13 years ago, looking at protein intake and lean mass in Health ABC. So this work showed how the loss of lean mass over 3 years was associated with energy adjusted total protein intake. And here we use the residual method of looking at total protein intake. And what you can see here is that those who were in the upper quintile lost about 40% loss of their lean mass compared to those in the lower quintiles. And the superscripts with different letters are those that are significant from each other. And you can see that definitely those who are consuming less than the RDA have greater loss of lean mass over time compared to those who are consuming above 1 gram of protein per kilogram of body weight. We see similar associations when we look at appendicular lean mass, such that those in the upper quintile have significantly less loss of appendicular lean mass compared to those in the lowest quintile. When we looked at this by type of protein, both animal and plant, we found that animal protein was significantly associated with the loss of lean mass and appendicular lean mass, such that those consuming more animal protein had less loss of both lean mass and appendicular lean mass. However, we did not find any associations between plant protein intake and change in lean mass or appendicular lean mass. One thing I will say with Health ABC, there was a lot more, there was more of a range of protein intake for animal protein than there was for plant protein. So that may have partly driven this association or lack of it for plant protein intake. More recently, we looked at energy adjusted protein intake and change in muscle cross-sectional area in Health ABC. And this was measured every 5 years, whereas the DEX is measured annually. And you know, surprisingly, there was no association between protein intake with muscle cross-sectional area. This may be in part because there were fewer people who had the muscle cross-sectional area measured by CT at the 5-year follow-up, so we may be partly looking at a healthy cohort effect. And also, the muscle cross-sectional area is just one slice of the thigh, and so it may not represent the whole body as far as lean mass. So then we started looking at the effect of protein intake on physical performance and muscle strength in Health ABC. First, we looked at protein intake and the short physical performance battery, or SPPB, And first I'll show the baseline associations. And you can see here again that those who consumed at least 1 gram of protein per kilogram of body weight had higher SPPB scores than those who consumed less than the 0.8 grams of protein per kilogram of body weight. The middle group was similar to the upper group, suggesting that those in kind of the moderate protein intake range did just as well. The difference between the SPPB scores was about 0.25 points, which is doesn't quite reach a clinical significant difference between individuals. Looking at gait speed, we have the 6-meter usual pace on the left and the 400-meter fast pace on the right. And again, you can see that the individuals who consumed at least 1 gram of protein per kilogram of body weight had faster both usual gait speed and fast-paced gait speed on the 400-meter walk than those who were consuming less than the RDA. And for the 400-meter walk, there was a stepwise increase such that those in the middle group were also lower than those who were consuming at least 1 gram of protein per kilogram per day. When we looked at knee extensor strength, we actually looked at this relative to appendicular, or actually to the leg lean mass in this case, in part because we were looking at protein as part of body size, protein relative to body size. And so both protein intake to body size and then body size to leg strength are going to be confounded. So looking at it relative to leg lean mass is how we decided to try to examine this outcome. And again, what we see here is that those who consumed at least 1 gram of protein per kilogram of body weight had significantly higher leg strength relative to lean mass than those who were consuming less than the RDA. So we then started looking at it over follow-up, and that what this shows you is the baseline 2-year and 4-year follow-up scores for the short physical performance battery. And what you can see is that at each time point, those who are consuming at least 0.8 grams of protein per kilogram of body weight of protein have higher SPPB scores compared to those consuming less than the RDA. But there's no protein by time interaction, and the decline in SPPB over time is similar across all groups. When we look at gait speed, both the 6-meter usual pace and the 400-meter fast pace, again, we see that at least for the usual pace, those who consume at least 0.8 grams of protein per kilogram of body weight had higher or faster gait speed than those consuming less than the RDA. When we look at the fast-paced 400-meter walk, there's a more separation between the 3 groups than there are for the usual pace. But again, in both of these, the protein intake by time interaction was not significant. And although all of these individuals decreased their gait speed over time, it was not associated with their protein intake. And then finally, looking at protein intake and relative knee extensor strength over time, again, we see a separation by the 3 different categories of protein intake, such that those who were consuming at least 1 gram of protein per kilogram of body weight had the highest leg strength at each time point. For this one, we actually did find a protein intake by time interaction. However, this is largely driven by the loss of lean mass in those consuming less than the RDA. So this interaction is really an artifact of the fact that we are dividing leg strength by lean mass, because it actually appears that those who are in the less than the RDA group had less of a decline over time, and that's because the denominator of lean mass was smaller. So in summary, for the physical performance and muscle strength results in health ABC, we did find that total protein intake was associated with worse physical performance, slower gait speed, and leg strength at baseline and over 4 years of follow-up. Although I didn't show it here, we also looked at both plant protein and animal protein and saw similar observations with physical performance, gait speed, and leg strength. However, both with total protein, animal and plant protein, there was no association with greater decline in physical performance, gait speed, or leg strength over the 4 years of follow-up. So we next switched gears and started looking at protein intake and self-reported mobility limitation, asking the question of whether or not protein might alter the disability trajectory. So although we didn't see any effect of protein intake on the rate of decline in performance or strength over time, potentially because at each time point, people who consumed more protein had higher performance or higher strength, they could potentially cross this disability threshold at an earlier time, such that those with lower protein intake might cross the threshold sooner than those with a higher protein intake, based on the results we saw from our physical performance and strength analyses. So when we looked at total protein intake with incident mobility limitation over 6 years, what we found was almost a twofold higher risk of incident mobility limitations among those in the lowest tertile of protein intake, which here was less than 0.7 grams of protein per kilogram of body weight. Even the group in the middle, compared to those who were consuming at least 1 gram of protein per kilogram of body weight, had a 50% higher risk of developing mobility limitations over the 6 years. So in these analyses, we also further adjusted the models for either total fat mass on the left and total lean mass on the right. And while the associations were attenuated, they were still significant after these adjustments. And you can see that for both after adjusting for fat mass and lean mass, that there was still about a 30 to 40% increase in risk of mobility limitations among those consuming protein in the lowest tertile compared to those in the upper tertile, which was the 1 gram of protein per kilogram of body weight. We also looked at the type of protein that was consumed, so animal protein on the left and plant protein on the right. And again, for both animal and plant protein, we found that those consuming the lowest of each protein type had the highest risk of incident mobility limitation over the 6 years of follow-up. And those in the middle group were somewhat in between. So in trying to determine whether protein intake could alter the disability trajectory, what we see is that even though there's no association with rate of decline, people do still cross this disability threshold sooner if they're consuming lower protein compared to higher protein. And so low protein intakes are associated with earlier onset of mobility limitations. So next we wanted to look at the association with protein intake and sarcopenia, as this was something that has gotten a lot of attention lately, although there are still a number of different definitions. The definition we chose to use for the analysis used a combination of the FNIH Sarcopenia Project definition of low appendicular lean mass adjusted for BMI. In part, we did this because Health ABC is an overweight to obese cohort. So the adjustment for BMI helps account for the fact that they might have higher lean mass just because they have higher total mass. And then an earlier study out of Health ABC had used the following definition to look at the functional side of sarcopenia, which was a low grip strength of less than 30 kilograms in men and less than 20 kilograms in women, or slow gait speed of less than 1 meters per second. And this is in part driven by the fact that Health ABC was recruited to be a well-functioning cohort. So, using somewhat less strict definitions of poor function helped increase the number of people who might develop sarcopenia in the cohort. And so for this analysis, we were able to look at it over 4 years of follow-up. And what we find is that those consuming less than 0.8 grams of protein per kilogram of body weight, or less than the RDA, had over a 2.5-fold higher incidence of sarcopenia over the 4 years compared to those that consumed at least 1 gram of protein per kilogram of body weight per day. And those in the middle group were also at higher risk, about 60% higher risk of developing sarcopenia over the 4 years. Now, one thing we wanted to look at was, as I said, there's a lot of different operational definitions for sarcopenia. And so we did a comparison analysis using the different definitions. And so the European Working Group and the International Working Group both use appendicular lean mass per height squared as their definition for muscle mass, compared to FNIH, which use appendicular lean mass per BMI. For gait speed, the European Working Group used less than 0.8, whereas the International Working Group used less than 1 meter per second. For grip strength, the European Working Group used the same definition that we used in Health ABC of less than 30 and less than 20 in men and women respectively, compared to FNIH, which uses a more stringent definition for low grip strength of less than 26 kilograms in men and 16 kilograms in women. And so, the cases of sarcopenia differed quite dramatically by the definition used to determine whether or not an individual develops sarcopenia. And I show here on the very right side the Health ABC results. We don't see any associations when using the European Working Group or the International Working Group sarcopenia definition. However, with the FNIH definition, those who consumed less than the RDA for protein were over 3 times more likely to develop sarcopenia, even though there's a very limited number of cases of sarcopenia during that 4-year follow-up. So switching gears a little bit, now I wanted to talk a little bit about protein and weight loss, as this is more of our recent work that we've been doing. And so Don Lehman's group had shared some information and studies looking at dietary protein and how it might affect the partitioning of both fat and lean mass during weight loss. We first looked at this in Health ABC, and what we found is that weight losers, and here the caveat is that weight losers might be those who are intentionally losing weight combined with those who might be losing weight because they might have some underlying condition. But nonetheless, weight losers in Health ABC, those who consumed higher amounts of protein lost less lean mass, as well as lost appendicular lean mass over the 3-year period compared to those that were consuming below the RDA for protein. So suggesting that those who consume more protein may be able to maintain more of their mass during weight loss. There was no association between protein intake and change in either lean mass or appendicular lean mass among those who were weight stable. However, we also saw a significant association among those who gained weight in Health ABC, such that those who consumed the highest amount of protein also had the highest gains in lean mass over the 3-year period. So, one of the things that, we do a lot of here at Wake Forest is intentional weight loss trials. And so, thinking about how protein recommendations are set, it may be that, if you're weight stable, the RDA for protein may be fine. But what happens when you're in a context of either weight loss or weight cycling, as far as protein intake and sarcopenia or loss of muscle mass and function? There is quite a bit of data, primarily from postmenopausal women, showing that calorie-restricting diets that are higher in protein are associated with greater fat-free mass retention than diets that are lower in protein. There's also other benefits that have been observed, including reduction in metabolism and greater weight and fat loss. And so there's been very few studies that have taken this into older adults. Don Lehman's group was one of the studies that did some early work in this. So we looked at some of our, one of our weight loss studies to look at a retrospective analysis. So this is data from Barb Nicholas's demo trial, which was in postmenopausal women, and they were all obese. And it was a 5-month trial that compared people who were assigned to a calorie reduced diet only, and the calorie reduction was 400 kcals per day, a calorie reduction diet plus low intensity exercise, and then calorie reduction diet and high intensity exercise. And the average weight loss across the group was about 12% or almost 11 kilograms. And there actually was no effect of the different exercise groups compared to diet only on lean mass. So what I'm showing here is the association between the amount of protein in the diet with change in lean mass and change in appendicular lean mass. And as you can see, the individuals who are consuming more protein intake didn't lose as much lean mass or appendicular lean mass over the 5-month trial compared to those with lower protein intakes. And this is even though pretty much everybody ended up consuming less than the RDA for protein. The protein content of the diet was based on a percentage of calories from protein intake. So with the calorie reduction, even though they were given an 18% protein diet, that led to low protein intakes. And this was a highly controlled diet, a weight loss study, where the participants received both their midday and evening meals from our metabolic kitchen and had a menu to choose their morning meal from. So, even in the context of being less than the RDA for protein, you can see that, going even lower increases the amount of lean mass that's lost. And this would be a problem in a lot of weight loss studies where individuals tend to just decrease the proportion of energy from different macronutrients rather than thinking about the fact that protein intake, the recommendation is not based on the percent of calories so much, but as the percentage of the body weight. So moving on from there, we did a small pilot study looking at protein intake, trying to get individuals to consume a higher protein diet during the 5-month weight loss trial compared to the lower recommended protein intake, at least based on a proportion of calories. And so this again was a 5-month weight loss trial. This time it was only looking at people who had a diet. There was no exercise involved. And what you can see here is that there was a similar amount of total mass loss and fat mass loss between the two groups. But the individuals who were consuming the higher protein diet, which was about 30% of calories or about 1.3 grams of protein per kilogram of body weight per day, had about half the amount of total lean mass and appendicular lean mass loss compared to those who were on the low protein diet, which even though it was 18% of their energy intake, was only about 0.6 grams of protein per kilogram per day. So this led us to thinking about the fact that, muscle mass is great, but we know that people tend to lose strength and function before they lose mass. And there are very few studies that have really looked at whether or not the loss in muscle mass also transcribes to a loss in function. So we have currently a trial called UPLIFT, or utilizing protein during weight loss to impact physical function. This trial is ongoing. It's a randomized controlled trial in overweight or obese older adults. So they had to either have a BMI of 30 or higher, or they could have a BMI of 27, provided they have had one other obesity-related comorbidity. The age range was 65 to 85 years, and we enrolled almost 187 to be exact, older adults to participate in this trial. And what we were looking at was the effects of a higher protein versus a recommended protein intake during a 6-month weight loss intervention followed by 12 months of follow-up. This was achieved by a protein supplement versus a carbohydrate supplement. So individuals who were in the protein arm also received a protein supplement that they were advised to take at their morning and noon meals, compared to those who were not on the higher protein diet. They received an equally caloric carbohydrate supplement to consume with their morning and midday meals. And we chose the morning and midday meals because those tend to be lower in protein intake, and because of studies showing that protein distribution across the day might be important, trying to increase the protein intake at meals where protein may not already be higher. So once they finished the 6-month weight loss piece of the trial, we then follow them for another 12 months. And during the weight loss portion, there's actually 2/3 that are on the higher protein intake diet, and 1/3 on the lower protein or recommended protein diet. And half of those stay on, so that there's still some people who are consuming protein during the 12 months of follow-up. And our outcomes for this study are physical function, both the short physical performance battery as well as the Health ABC expanded physical performance battery, as well as muscle strength. Secondary outcomes, we're looking at weight loss maintenance, fat to lean mass ratio, thigh muscle volume, and also intermuscular adipose tissue. And these are primarily derived from the CT scans, but we are also collecting DEXA at each of the time points as well. So as far as implications and future directions of this work, it appears both from data that we've looked at here in Health ABC, but also others, that the current protein and recommendations may not be optimal to maintain muscle mass and function in older age. Some of the things to consider as protein source. In general, we found that both animal and plant protein were both associated with better function, mobility. However, they were not both associated with lean mass. Per meal protein quantity has been suggested as something that should be taken into account. In Health ABC, we're unable to look at that because we're using a food frequency questionnaire, but there's others who have looked at protein per meal and have shown that trying to achieve this kind of optimal range of 25 to 30 grams of protein per meal does seem to have some impact on both physical function and strength. So there may be something to try to distribute protein more evenly across the day. Others have also looked at timing of protein intake, so whether or not the protein intake is done in close temporal proximity to exercise, as that might increase the uptake of protein into the muscles. And then also specific amino acids, particularly leucine and branched chain amino acids, should also be considered as far as different avenues of protein when looking at muscle mass and function. So where do we go from here? I think there have been a number of studies looking at protein intake in the context of exercise, as well as on their own. And in general, it doesn't seem that protein intake does a whole lot for muscle mass and function. However, we have to think about where people are starting out. So if someone's already sufficient and consuming adequate amount of protein, increasing their protein intake may not have a whole lot of effect on their function going forward. I think in particular for older adults who are losing weight, I know there are studies in younger adults showing that having higher protein intake either does help improve muscle mass or it does not. When you're thinking about an older person who is losing muscle mass and function at an accelerated rate, it may be even more important to put some consideration and emphasis on a higher protein diet during weight loss, especially if it's intentional, but even in unintentional weight loss settings. Because I think, whether looking at mass versus function, most older individuals are more concerned about staying independent. So mass may not be the outcome of interest for most older adults. They're more likely to want to make sure that eating this higher protein diet would improve different precursors of disability, such as muscle mass and function, and also delay the onset of disability so that they can maintain their independence. So with that, I would just like to acknowledge some of our Health ABC collaborators. Here at Wake Forest, Janet Tews is the biostatistician that I've worked on with all my Health ABC analysis. We also have collaborators at NIA, Ann Newman at Pittsburgh, Fran Tulaski at University of Tennessee, and Marlene Visser at Frye University as well. And I can't forget about Steve Prochaski here at Wake Forest. He's who brought me here. And also, as far as the weight loss studies, Barb Nicholas and Leon Lenchek have been involved with those here at Wake Forest. And then our funding from NIA that has supported both the Health ABC analysis as well as the weight loss studies here at Wake Forest. And with that, I'll open it to questions.
Okay, thank you very much, Denise. I just want to, what a wonderful seminar. I want to remind everybody, if they can, to submit their questions through the Q&A function. And we already have one. This comes from Alice Lichtenstein. She says, thank you, and very interesting data. With regard to the bottom line, what is your opinion about how to best formulate RDA recommendations? Should they be done on the basis of total body weight or on the basis of lean mass or lean muscle mass, for example?
Yeah, that's a really interesting question, because we actually have looked at some of these same analysis using an adjusted body weight. And in large part, that's because, at least in the US, we have such a preponderance of obesity. So it's really difficult to know whether it should be based on total body weight, because that is your mass, or whether it should really be based on kind of more metabolically active tissue like lean mass. However, for general recommendations, most people don't have access to a DEXA to have lean body mass done. You can get your bone density done, but most clinics don't measure body composition. So I think for general recommendations, keeping it to the total mass. And then I guess the question becomes, what do we do with people who are obese or even overweight? Do we try to adjust that to a more somewhat normal weight, whether that's somewhere in the mid-range of the overweight category? I've also seen some people adjust it to a BMI of 23.5 in the middle of the normal weight category. So there's, I've seen different ways of trying to deal with the kind of body size issue when it comes to protein, and whether the protein needs are really dependent on metabolically active tissue versus just total mass. But it's a good question. It's a hard one. I've been asked that several times.
Naomi Fukagawa asks, do you have any information on what has happened to the Health ABC cohort? And the question really relates to, have you looked at mortality and protein intake, protein status?
We have not looked at mortality in Health ABC. I know there are other studies that have looked at protein intake and mortality. The data is a little mixed, sometimes even actually showing higher mortality with higher protein intake. The Health ABC cohort stopped following participants, I think, at year 18. But that's 18 years of follow-up with, I think in the end, at least 2/3 of the participants had died by the end of follow-up. So that's definitely something we could look at, is mortality. We've looked at other outcomes with protein. Most recently, we looked at bone mineral density and fractures, though we didn't have very many fractures to really be able to look at that, but we did see an association with protein and bone density.
So I'll take chairman's prerogative here and ask one question that I was curious about, Denise. It looked like it was really nice that you tried to compare sort of the relationship of low protein intake to the various incident sarcopenia measures using the different definitions that we're all sort of struggling with now, right? I was curious about how have you thought what components of the different definitions do you think really drove sort of either the positive association, the high relative risk, or the lack of an association? Have you tried to tease that out? Obviously, I know that the grip strength is much more inclusive in some of them, but I think there's some other subtle things there. I was wondering if you had thought about that a little bit.
So I think it really is the muscle mass piece of the sarcopenia definition that tends to really separate. There's not much concordance between the four different, or at least the three different definitions, the European, the international, and the FNIH. If you look at those, the people who end up being considered low muscle mass for the European and international working group are very different than the people who are in that same group from the FNIH definition. And that's largely, I think, because the FNIH definition accounts for BMI. And so in some ways, kind of getting back to Alice's question, where you're thinking about protein as far as kind of metabolically active tissue and not just total mass adjusted for height. So that seems to be where most of the discrepancy comes from when looking at it across the different definitions. I mean, a little bit with the different grip strength and gait speed, but primarily because Health ABC was so well functioning at baseline, it's very hard to find sufficient amounts of people who do have low grip strength and did have low gait speed at the baseline visit to go forward. So,
got it. Thank you. This question is from Marina Moreno. Again, thanking you. She asked, I wonder if you can talk about benefits, risks of some amino acid manipulation, such as methionine restriction in the elderly.
That's not one that I've really looked at. In general, I don't see that, that's something that is going to be an issue for most older adults. When it comes to protein overall, even those who, have impaired kidney function can actually consume higher than the RDA for protein. And in fact, even up into, this 1 to 1.2 grams per kilogram of body weight is still considered a reasonable amount of protein intake for those that have impaired kidney function. I don't know that I'm really answering the question there, but I haven't really seen much on that.
I guess I'll take the opportunity to ask another question, Denise. I think you looked at protein intake and self-reported mobility disability. Yeah. Have you tried to look at a more sort of discrete outcome? People have used like the inability to walk 400 meters. And I think that data was collected in Health ABC. Have you looked at those numbers?
Right. So in Health ABC, we have the 400-meter walk. It's a little bit different than like the Life 400-meter walk, in that it was done at a pace as fast as someone could maintain for the entire 400 meters versus just a usual pace. So it's more of an endurance walk. So while we could look at the 15-minute cutoff or whether or not someone couldn't complete it at all, the walk itself is a little bit different than what is usually considered as having mobility disability based on the 400-meter walk. We haven't looked at that. That would be interesting. Another thing we could do is also look at things like the short physical performance battery. There are some standardized cutoffs. So, is it associated with someone going below 10 on the short physical performance battery would be another thing. But we haven't actually looked at, true kind of, I guess, maybe clinical functional outcomes to see, if there's an association with that rather than just the continuous measures. But that's a good suggestion.
I do think that there were people, even though I know it was the fast-paced 400-meter walk, I do believe, at least in some of the early reports on that data, that there were people that were unable to complete the walk, I think.
Yeah, so at baseline, there's actually The 400-meter walk probably has one of the fewest sample sizes in health ABC, in large part because a lot of people didn't even attempt it because of different health conditions. So a lot of people were excluded from doing the fast-paced 400-meter walk at baseline and then subsequently at follow-up. So you'd have to kind of tease out the people who aren't able to do it because of health reasons versus those who maybe start and can't finish or don't finish within that time allotment. Because I think those would be very different types of people to be looking at in regarding their health and protein.
Very good. Well, I'm just gonna I don't see any additional questions, so I think we will conclude now. Thank you for an excellent presentation, Denise, and thank you all for attending today. And we'll see you all at our next seminar. Thank you all very much. Oh, wait a minute, one more. Oh, thank you very much. Okay, that's great. Thank you all.
Thank you.
Okay. That was excellent, Denise. Thanks so much.
Thank you. Yeah, it went faster than I thought it would. I was like, ooh,
yeah, it was good talk though.